Hi, everyone. Welcome to my talk. I will be talking today about the treatment of eating disorders, but in particular, we're going to kind of narrow that topic down a little bit as we go along, but I appreciate everyone taking the time. For those who don't know me, my name is Tom Hildebrandt. I'm a psychologist, clinical psychologist, the professor of psychiatry here at Mount Sinai, and I have the pleasure of directing the Center of Excellence for Eating and Weight Disorders. So as you guys, or as everyone comes in, hopefully this will work, but I'm going to move along and get us started. So I have some disclosures. I'm a scientific advisor at New Inc. I won't be talking anything about my work with them today. We're going to focus on a different population, but I will disclose. And let me give you just a quick outline of our discussion of our journey today. So I'm going to start with the question of what is an eating disorder, and then hopefully kind of narrow that focus down to restrictive eating disorders, particularly anorexia nervosa. And as we move on from kind of understanding what an eating disorder is, we'll talk specifically about what the best treatment options are. And what I hope to do is kind of present both a sobering picture, one that identifies some of the challenges that we have, but offers some hope as well for those who suffer and for what things we can bring to help relieve some of that suffering. And then I'm going to take on maybe the more ambitious challenge of trying to align our understanding of what an eating disorder is with treatment development, and talk specifically about some work that we've done developing disgust-based interventions for anorexia, and how that might have implications for how we design or understand behavioral treatments for these disorders. And then hopefully kind of stimulate some thinking about how and what role pharmacology or even dietary interventions might have as we unify our understanding of what eating disorders are and the treatments we hope to deliver. So with that being said, as sort of a point of reference for those who might not be fully aware, the following categories are what at least DSM, our Diagnostic and Statistical Manual, defines as eating disorders. What I'm going to do today is really focus on the top category here, anorexia nervosa, although I think a lot of what we're going to talk about will be relevant to avoidant restricted food intake disorder as well, ARFID, as we understand it. So context. I usually like to do this when I'm talking about eating disorders in particular. I like to talk about kind of the medical history and give a little bit of a understanding of kind of the history that brought us to our understanding of anorexia today. We can find discussions of anorexia in medical texts dating all the way back to antiquity. And the term anorexia and its association with illness was already being described in this pattern of persistent restriction. In the sort of Victorian era, we first sort of see anorexia being kind of moved into the realm of psychiatry, and the food refusal documented in those populations in the asylums being determined as a type of insanity. Richard Morton is often ascribed with or accredited with the first medical description of anorexia, late 1600s. And from that description, I believe this might not be, this is not the right slide show. Okay, I'm having some technical issues. I'm going to stop the share for a second and just ask if we can maybe figure out what's going on here. Let me try to reshare this. Still, it's not showing certain things. Okay, we'll move on. Okay, anyway, so the point I was attempting to make was that even in descriptions early on with anorexia, we were able to or the description sort of moved the illness into the sort of realm of psychiatry and termed it kind of a neurotic illness in the sort of modern era of psychiatry, beginning in the 1950s with the DSM. And I think what's interesting about that is that as it sort of got moved in psychiatry, the focus was actually shifted sort of more on the sort of neurosis part of it and less on the anorexia part of it. And I think that that's had implications for how we've gone about trying to treat it over time. And that kind of treatment model has had limitations that we're going to highlight over time. And I think if we take anything from this talk, it's probably that we have to kind of better understand eating disorders in particular, but particularly anorexia nervosa at its core, not necessarily the assumption that the kind of anxiety part of it is the primary driver of the illness. Okay, so at this same time that we sort of enter the kind of modern definition of anorexia nervosa, we also had kind of in parallel a side effect of World War II, the kind of great starvation experiment, as we termed it. That starvation experiment, headed by Ansel Keys, really gave us our best understanding of what the effects of starvation are. For those who don't know, I encourage you to look it up, but the starvation experiment was really kind of unique from a scientific perspective in that we identified 36 individuals, set a baseline of roughly 3 months, had them intentionally starve, but in a sort of controlled way, reducing their body weight significantly, much like what we see in anorexia nervosa, and then focused really on what the rehabilitation problem or obstacles were in trying to sort of physically restore people back to a healthy weight and healthy functioning. What's come out of that that are maybe even more interesting are some of the psychiatric or other observations that were made during this experiment. And almost universally, we saw increases in food preoccupation, slowing of the gastric symptom, pains, and other somatic experiences that increased in the context of starvation, along with heightened depression and anxiety, and difficulty with feelings of loss of control, and particularly guilt and distress associated with eating and the feelings of fullness that came after. So that takes me to where I think, hopefully, we can really kind of fundamentally kind of define what an eating disorder is. And that's a disturbance in eating, according to our DSM. And those categories that I showed before, kind of represented in concentric circles here, we really can conceptualize, at least clinically, as encompassing 2 types of disturbances in eating, food avoidance and loss of control or overconsumption. And the diagnostic categories, which have different prevalence rates sort of reflected in their size here, move from anorexia nervosa, which is primarily categorized in that sort of food avoidance model, to bulimia nervosa, which sort of has a split between food avoidance and loss of control over eating, to binge eating disorder, which might be primarily defined by that loss of control over eating, but still experiences specific types of food avoidance as well. Our orphan category, avoidant restrictive food intake disorder, is still being better understood, but really is the only disorder that sort of primarily exists in this food avoidance category. Well, today we're really going to try to focus on that food avoidance. We're going to try to focus on our specific eating disturbances that fall under this category. So let's deconstruct that for a minute. If I'm an individual, particularly with anorexia nervosa, and I'm trying to navigate my environment, my brain is sort of constantly trying to make sense of sensory information. And part of that sensory information, some of which is reaching consciousness, some of which is not, is asking, what does my body want? And I'm trying to answer that question through attention, observing the different signals and trying to make sense of them as they come into my body. But as I interact throughout the day, I also am trying to figure out what the environment is telling me to do. can't solve it all internally myself. So I receive some input, some information from the world around you. And often we're bombarded with food cues, things that are stimulating or signaling, the time to eat. Well, that alters that sensory information and kind of gives us a signal, an alert, an anticipation that it's time to eat, that food is coming. And then we have to adapt to that signal. Imagine in the case of anorexia nervosa that some of that signal is a visceral signal. And visceral, what I mean is sort of the sensory information from the viscera, from your body, how you kind of feel in your own skin, is being sent, and you're trying to make sense of that. But it's really attached to and creates kind of an image that you feel like doesn't really fit you, that makes you feels different than you are in your own skin. And you run across those same cues. Now you're trying to make sense of the world and it's time to eat. And let's say you do encounter that food and you actually eat it. Well, that signal then gets amplified. And along with that signal, we have now this sensory information from the body that gets attached to that overall belief or idea that you don't fit in your own skin. That gets you to stop eating. In fact, it might even get you to avoid eating. And if you avoid eating, what are the impact of that sort of visceral signal is now a stronger sense of safety. You actually get a relief from avoiding eating, a relief of that discomfort, or at least anticipated discomfort associated with eating. And so when we think of food avoidance, we really kind of think of that model where anticipating eating kind of stimulates this attention to all the sensory information. And then eating itself actually amplifies that visceral signal. And you kind of create a connection between those feelings, we'll say, of fatness and self-disgust. And we're going to talk about disgust a bit more as we go along. And then avoidance of that eating really kind of probably even robustly relieves some of that sensory discomfort and creates sort of an idea of safety. So what are the observational evidence? What evidence do we have that food avoidance actually exists in this population? Well, if we look just at energy consumption in folks with anorexia, if we look at laboratory eating, kind of a buffet meal, we'll think about it. And folks with anorexia nervosa are eating, roughly half that that healthy folks are in that kind of environment. And now we might say, okay, well, that's an artificial environment, it's laboratory eating environment. What about the real world? Well, we see basically the same pattern in a 24-hour recall. So if we ask the same question, we see pretty consistently that folks with anorexia nervosa are eating less than those that are healthy. Well, how does that behavior change in the course of treatment? Well, in really sort of a landmark study, I think, in our field, and trying to understand this, Cisco and colleagues looked at changes in a single meal replacement kind of laboratory eating paradigm, and looked at whether over the course of really intensive inpatient treatment, we were able to change that behavior. And what they found was marginally. As you can see the lines here for the individual subjects that participated, there was very little on average change overall, though a couple people increased. The red line on the top really marks what we would expect a healthy individual to have consumed during the same kind of laboratory meal. And so you can see only one person really kind of crossed that threshold. Maybe even more remarkable is that these individuals were used to eating roughly 800 calories during each one of their meals while on the inpatient unit. So this is a distinct deviation from what they were doing on a day-to-day basis over the course of treatment. Does that food avoidance, is it predictive of relapse? And the short answer is yes, the little data that we do have on it. And that comes kind of in the form of not necessarily just calorie restriction, but a very specific type of calorie restriction. And we can kind of quantify this as eating less energy dense foods. We know that folks with anorexia eat less variety as well, but that less energy density is really what's predictive of relapse. And if we look at where that lack of energy density comes from, it's really the avoidance of consuming dietary fat. Now that kind of makes sense in the grand scheme of things. But when we think about, well, what makes that particular aspect of nutrition avoided? Well, there is some at least correlational evidence that anxiety ahead of a meal is associated with that difference. And so now we sort of get into this idea that we have a fundamental disturbance in eating that defines eating disorders, food avoidance primarily for anorexia, and that there's a relationship between some kind of anxiety and avoidance of dietary fat. So now let's take that and hold that idea for a second and think about what are our treatment options. Well, as a point of understanding, what is our obstacle? What is the major obstacle that we have to face while treating our patients? Well, food avoidance is costly, lethal, and debilitating. And these are sobering statistics about the treatment and the amount of public health costs and personal cost associated with the time course of anorexia. Not only do we have the second highest mortality rate observed in this population, but we have a chronic relapsing course where only 30 to 50% will hit recovery in their lifetime. And the majority will have at least one relapse over the course of that lifetime span of the illness. If we look at the per year costs per individual, we're looking at roughly $27,000 a year sort of public health costs per individual, and added another 110,000 lost to well-being. That's remarkable. That's a remarkable obstacle that we have to deal with in the context of providing treatment. So what treatments are there? Okay, so hopefully maybe pharmacology can help. Well, the results for the handful of clinically controlled trials looking at different types of medication have been pretty inconclusive. There really is no robust pharmacological option to treat the symptoms of anorexia, with the exception of a little bit of promising data for olanzapine, where there's a small but significant increase in overall weight and reduction in symptoms of obsessive compulsive disorder in the context of treatment relative to placebo. What about psychotherapy? Well, if we look at the adult literature, maybe an even more sobering kind of conclusion is that, at least for outpatient psychotherapy, there have been 13 randomized controlled trials. There are no significant treatment effects. Treatment as usual seems to be comparable to specialty treatment, and in some cases, one might argue, is better because the dropout rates are less on average. And so if we think about that, we really run into the sort of perplexing problem of treatment. Well, is there hope in terms of at least the traditional models in psychiatry? Well, the youth picture is a little bit different than that adult picture for anorexia. And we have a gold standard treatment, family-based therapy for anorexia nervosa. And it comes in multiple forms, but of the 25 clinical trials, the majority show within subject improvement, but relative to active or educational interventions, there really is no consistent evidence that FBT is better. That being said, several of the studies have shown significant effects over other treatment. And really, we need to sort of understand that better in terms of what type of family therapy might be better for what individual. The other alternatives are inpatient or residential programming. And while inpatient stabilization does a good job of restoring folks body weight wise, the relapse rates are extremely high, noted before. And residential programming, which offers another alternative, we really don't have quality data on recovery, particularly in the long term, and certainly no controlled studies of whether residential programming improves outcomes over time. So what is family therapy? So if this is the most promising treatment and we tend to do better in sort of time course of the illness with family therapy, what is it? Well, phase one is really focused on refeeding and weight stabilization, often termed a home hospitalization. And parents are charged with meal responsibilities. They sort of take the charge of that hospital staff, and they become the authority to sort of dictate and ensure follow through with all of the meals. After that has achieved at least some level of weight restoration, phase two focuses on sort of returning the control, the sort of autonomy of eating back to the adolescent. And that's a gradual transition. So it's not just one day it's decided and total responsibility is provided back to the child, but it's a gradual transition monitored by the parents along the way. And then phase three is a reintegration of that individual back into their adolescent life. They get to focus on other adolescent issues that may have coincided or predated the cause of the illness. This being said, early response in the context of family therapy is really what predicts response. So if you achieve a 2.65 kilogram weight gain in that first 4 weeks, you're going to do well in treatment. And that's what the data sort of reliably shows. Several studies have shown this now. Changes later in treatment, we're not really sure if that's meaningful or important in terms of the recovery. So we asked the question, well, what changes early in treatment? And if we really kind of think about it, you're confronting food avoidance. And part of the way that this is done is by incentivizing changes by parents and removing sort of positive alternatives, removing the value of safety and increasing the value of sort of attempting to approach food. So what would happen if we targeted food avoidance in addition to that weight gain early in treatment? And we asked that question and thinking about what the mechanisms of family therapy are. Well, reduction in food avoidance via exposure was, first mentioned about a decade ago. And we sort of conceptualized that family therapy as an opportunity to do two things: reduce that safety experience, but also increase the tolerance to the aversive experience of eating. And this gets back to that fundamental idea of our folks with anorexia are reporting feeling different, feeling unwell when they eat in a different kind of way, a way that helps maintain restriction as opposed to seek to relieve it. If we look at self-report data about what patients are reporting in the context of treatment, they're reporting, persistently pre-meal anxiety and feelings of guilt and hostility after eating. So if we ask them, kind of in the context of regular treatment, what affectively they experience, this is what they self-report. There are also sort of well-known or documented kind of disturbances in reward learning that occur and have been studied in the context of anorexia. Particularly prediction error and punishment. We know that folks with anorexia seem more sensitive. They have sort of a stronger prediction error response, and their brain anyway seems to be more responsive to punishment or psychophysiologically more responsive to punishment. And that there are sort of alternative elevations in the saliency network, particularly to reward. There are also deficits in types of learning, particularly extinction learning. And we were able to demonstrate that prefrontal hyperactivation, sort of maybe an over reliance on prefrontal control of that learning paradigm sort of impairs or is associated with impaired ability to sort of distinguish the relationship between a food cue and that kind of anxiety or that negative affect. But it does ask pose the fundamental question of whether food is actually rewarding at all. And so we moved away from reward learning in that our conceptualization or our understanding of anorexia and focused on food as kind of an aversive stimulus. And there are creative ways in which you can study that without having to actually ask individuals. One of those is facial electromyography, which is studying the kind of automatic facial response to certain cues or prompts. And we demonstrated actually in two different studies that that facial response suggested sort of actually a disgust response to food, not necessarily fear or other types of anxiety. And that in particular, that disgust response interfered with extinction. So let me show you what that looks like. This is kind of the just behavioral outcomes from one of these kinds of experiments. And you can see, both healthy individuals and folks with anorexia kind of discriminate between, two different stimuli, the one that's associated with food in red, the one that's not associated with blue. And then when you kind of trick them halfway through the experiment, you kind of change the association, you should see discrimination reverse. You should see, the blue dots go up and the red ones go down. And that doesn't really happen with anorexia. They kind of become indiscriminate, unlike those with control. Well, when you look at physiologically what's happening during that acquisition, folks with anorexia are experiencing at least facially kind of a disgust response to that pairing with food. And the degree to which they did predicted how impaired that extinction was in the second half of the experiment. So what if the anxiety driving food avoidance wasn't really fear, but actually disgust? And disgust offers us a number of important opportunities, I think. You know, a well-described human emotion dating all the way back to Darwin, the idea of kind of avoiding food is not only adaptive, but pervasive, conserved across species, is reflexive, and maybe important for learning. It has a couple of specific components to it. One, it's very hard to extinguish. So once you've created a disgust association with something, very hard to break that down. It's very hard to update that learning and alter it. And there are a number of different reasons for it, but reliably that is true. Another thing, it's picked up socially. You don't have to be actually exposed to the disgusting thing. You can hear about it or see someone be exposed to it, and that alone will sort of create the association for you. So it has a very strong social connection as well. Things that may be particularly relevant for our patients. So how does disgust relate to eating? It's a good question. So we study in a laboratory autonomous eating, which involves asking an individual to sit in front of, in this case, a container full of a milkshake with unknown calorie content. They're not told much about what we put in it, other than it's things that they have had before that they've tasted, and that they're asked to sort of replace a meal. They're asked to eat enough to replace the meal, breakfast or lunch, depending on when you time it. And they're asked to do this without prompting. So we leave them alone, and we put them in front of a low arousal video. In context of our experience, that video is Cosmos, one that doesn't have shape or weight triggers or other things that might, contaminate the experiment. And they're given about 30 minutes to eat as much as a meal. And then when they're finished, we can measure how much they ate. We can measure the rate of eating. But what we've also done is collect video recordings specifically focused on their face during this task. And part of it's a side effect of just wanting to ensure compliance. We want to make sure that folks are safe and that they don't engage in purging or any other kind of behaviors during the task. But also we're able to sort of collect this video data and use kind of a deep learning classifier, an AI classifier, to classify emotions. We can classify up to 9 different ones, but we collapsed it into a negative, positive, and disgust. And I'm just going to show you a tracing of an individual subject. This was from 45 adolescents, 12 to 18 with anorexia nervosa. And as you can see, these lines, the tracing suggest the dotted lines here being when the individual took sips of the shake. These sort of tracings are the presence of different emotional states, in this case, positive, negative, and disgusted. And as you can see, there's a lot of variability over time, but as we zoom in this case, right around this sip right here, we saw an interesting relationship, which is, although disgust is not the predominant emotion, there are a whole lot of negative general emotions and very little positive emotions. But what we see initially here is after eating a spike in disgust, followed by negative affect that sort of lagged behind it. And so what we did was use a sort of a complicated statistical model to look at sort of the time course, the individual time series of the relationship between eating, disgust, positive and negative emotions. And we sort of asked to look at not just the autocorrelations, how, is eating correlated with eating? The short answer is yes. Is disgust correlated with disgust? Yes. So all of these account for that automatic correlation that happens just in the context of time. We're more interested in the lagged associations. Is there a relationship between eating and emotions that's stable over that entire time course? And that's what we found, that eating was followed by, not preemptive, but followed by disgust. And so that there was a coupling, an association between eating and disgust that was reliable across subjects. And that happened, across the whole time series. So we could see as individuals were consuming at different time points, they sort of reliably were eliciting disgust. That disgust appears to be sort of the pathway towards a relationship with negative affect. Positive affect, not so connected to all of the other emotions, at least not above chance in this model. But we sort of, have a pathway here that suggests that disgust is playing sort of a, we'll call it post-prandial, post-eating role in the affective experience of eating that we were able to code without having to stop individuals to ask them how they were feeling. And so this gets out some of the confounds of self-report bias and other things that might occur and have been present in other studies of the same phenomena. So I think, this for us confirms kind of what we were thinking along, that disgust really does have a specific relationship with eating, and it may actually partially explain some of the negative affect that individuals are experiencing over the course of eating. So can we adapt family therapy to address disgust? Well, this is something we sought to do, but how do you do it? Well, how do you extinguish disgust? If we've already talked about it being sort of this innate protective emotion, something that prevents you from eating, very resistant to extinction, in part because reducing that extinction could be lethal. How do you do it? Well, if you dig into the literature, there are two kind of methods that from experimental literature that emerge. One is counter conditioning, the other is stimulus reevaluation. And those are sort of jargony terms, but the key here is that they're focused on shifting valence and not necessarily cause and effect. So they're not necessarily trying to convince you that the thing that you're being exposed to is not, in our case, disgusting anymore. They're trying to shift whether it's positive, neutral, or negative. They're trying to move that valence shift along the way. To get at this, particularly given the somatic complaints that are common in our patients, we sought to focus on those visceral sensations, those stomach-related visceral kind of component to this in the context of exposure therapy. Now, most people will think of interoceptive exposure in the context of panic disorder, where you're exposed to rapid increase in heart rate or the dizzying effect, being spun in a chair, for instance, is often done to elicit the symptoms so that you have an experience of tolerating the symptoms in the context of safety, and you're able to learn that you can tolerate those symptoms and move on. Alternatively, with disgust, our goal is not just to expose the individual to those, but also to pair it with positively valenced things, and hopefully to learn how to reevaluate those experiences in a mindful, non-judgmental way. So interoception, it's an interesting construct, far too broad for me to cover in detail today, but we do know there are well-documented disturbances in interoception in anorexia. And it may very well account for that perceptual disturbance in body image that's sort of characteristic of the disorder. And we really think it's probably specific to that visceral sensing of what's going on inside one's body. However, the majority of the documented effects, impairment in interoception, are really driven by self-report measures. So one of my favorite experiments, and if you have a chance to read this and you're interested, I think really informative in terms of trying to understand interoceptive deficits in anorexia, was done by a group, senior author Jamie Fusner. It's in Frontiers, it's easily available, but I encourage you to read it. It's a complicated experiment, but the take home here is that what they did was pharmacologically increased heart rate relative to a saline control. And they did it purely in a panic condition where all they were doing was increasing heart rate. They did it ahead of a 1,000-calorie meal, and they did it after a meal. All folks with weight-restored anorexia, so weight is not a confound in this. Physiologically, these folks are relatively similar, at least cardiac-wise, and in terms of weight. And you can see here the folks with anorexia with the red lines have a higher anxiety report across panic, pre-meal, and post-meal. But maybe more interesting is that when you control for this difference right here, that changes. So the relative difference, so increasing heart rate with a higher dose of sort of medicine actually had the same effect on healthy controls as it did folks with anorexia. What was different was they were already anxious to begin with. And I think that gets at the trait that we've been trying to, that we've identified historically over time in this population that we often attribute to the pathology, but might actually be just sort of innate to the individual. In any case, I think the take home here is that the cardiac version of this sort of interoception, observing or sensing within one's, cardiorespiratory system does not seem to be particularly different between healthy controls and anorexia, even associated with a meal. So while they may well have higher rates of anxiety or discomfort reported, even if their heart rate changes than those that are controls, it may just be a baseline difference. It leads us to the question that maybe that interoceptive disturbance isn't really cardiorespiratory, but is perhaps specific to the gut. And specific to the gut would have important implications for understanding disgust. That takes us to interoceptive exposure. So what is it? It is a 6-session, at least the module we developed, 6-session family-based intervention. It involves in-session exposure to a shake very similar to what I showed you before that was characterized by uncertainty. So we didn't tell folks what was in it. And we asked parents to practice at least one time a day doing this kind of exposure with their children at home. And the goal is really to tolerate the discomfort, not necessarily to extinguish it. We train them how to do counter conditioning. So we have them pair positively valenced things with feeding, but particularly focusing on that post-meal visceral symptoms. So while you're feeling full and bloated, you're also listening to your favorite music. And it's not cause and effect related. It's not if you do this, then this. It's paired in time. When you have these sort of visceral symptoms, you're also going to associate it with something positive. And that's what we train folks to do on a day-to-day basis. In addition, we taught them distress tolerance skills, mindfulness, positive coping, will for discomfort, and acceptance. Now, these were done to increase tolerance. They were not used as a distraction in the context of the exposure. When we did the exposure, we focused on the exposure and the counter conditioning at that time. So the ultimate question, did it work? Does interoceptive exposure reduce food avoidance? This was our clinical trial. So we did it in 60 individuals. This just sort of highlights the study flow, the visits. Here's our consort, so 60 individuals for intent to treat. Our primary outcomes, only some of which I'll report today, in part due to time. But we had the laboratory meal. We had a whole bunch of self-report data. We used measures of extinction learning as well as reversal learning, sort of a different type of extinction learning. And we used fMRI. So we were interested in the neural circuits associated with these potential changes in learning. This is the results from our laboratory meetings. So treatment A here, and sort of our blind analysis of this, was we saw about 100 calorie increase in single item meal in our folks that received interoceptive exposure. Those who received classic FBT had about a 50 calorie increase. So about twice as much consumed over the course of that 6 sessions in this autonomous meal. The multi-item meal, which is sort of a different version, maybe more complicated, but not characterized by uncertainty. Folks get to choose from a whole plethora of different food when they're making these decisions. And in comparison to healthy controls, as you can see, they're still different, but our group A, which was our interoceptive exposure group, was again about 100 calories, consumed about 100 calories more during that meal than the folks in FBT. When we talked about extinction, we used a paradigm that looked like this. You pair a colored kind of stimulus with, in this case, either a rotten or a fresh food. And then extinction was just pixelated versions of that presented with the same colored square. So acquisition, pairing those two together, and then extinction, presenting it in a pixelated form. This shows the behavioral data. Everything's the same. I'll have you focus right here on extinction. So this is our valence rating from yucky, neutral to yummy. And what you can see here is that our treatment A, which was family-based interoceptive exposure, we actually shifted. We had a greater shift towards yummy ratings for palatable food, whereas they remained yucky in our healthy control, or sorry, our classic family-based therapy. So there seems to be a specific effect to change in behavior related to that shift in valence. This is some of the imaging results, which we're still kind of going through. As you can see, we found a greater change, panel A here in ventral medial prefrontal cortex. We think associated perhaps with that valence shift that was noted before in folks with interoceptive exposure from pre to post relative to those who got FBT. You can see the ventral striatum, both interventions had a reduction in activation from pre to post during that sort of association task, but the treatment groups were not different from each other. If we look at connectivity, you can just see the top two A and B lines show connectivity between rotten and palatable foods. This is differences between adolescents and controls, that same group. And as you can see, there's sort of network differences, particularly in the connectivity between healthy and rotten foods. A stronger, more diverse connectivity between insula, amygdala, ventral striatum, and VMP, ventral medial prefrontal cortex in our anorexia group. So this sort of demonstrates our theory that this aversive circuit is probably characterized by sort of greater connectivity in our low weight eating disorders. So what are the implications of this? So what are the effects of this treatment? Well, the theoretical implications are disgust may underlie food avoidance. It may be part of what we've missed and haven't focused on, in part because we were focused on the temperamental characteristics of the disorder as opposed to, or as the presentation, as opposed to what might actually underlie the food avoidance. And I think it explains some of the difficulty in why changing behavior has been difficult. So as much as we've exposed individuals to food in the context of refeeding, they haven't learned actually to continue to approach that food. So I think this model kind of informs our attempts to really kind of shift to changing the valence and not necessarily the affect and its consequences. And I think that's where we've been trying to make folks less anxious in hopes that they would eat, as opposed to trying to increase the approach behavior, assuming that we might not be able to change the affective response. In terms of saliency and reward network, I mean, I think this is still an open question. We're learning a lot. It does appear that there's at least some effect of interoceptive exposure on activation in identifying brain regions in the context of aversive learning and the exposure to it. But really, does disgust modify the saliency network and reward network? And one of the main questions we have is there's a shifting valence-wise. Disgust can be funny too. And if you think of, if any of you have small children, how delighted your children can be by some of the most disgusting things, the laughter and joy that they can experience when being exposed to it. So is this possible? Is disgust sort of a one-trick pony in that way? Or can it, from a valence standpoint, really run the gamut from sort of a positive to a negative affect? Future directions. Can we modify this aversive learning system pharmacologically? The cannabinoid system would be a strong candidate for this. There's evidence that it can enhance extinction learning. We think cannabinoids also have the potential to affect things like appetite. And so if you're able to alter the system in the appropriate way, we might be able to offer some relief or some advantage in terms of this difficult process of having to learn to relate to food differently. A second, maybe even more provocative question is, does does simply increasing consumption of dietary fat matter? If you directly target this kind of food avoidance pattern, does it have, is there a nutritional basis to some of this avoidance? For instance, could increasing the polyunsaturated fatty acids that are precursors to those cannabinoids from a dietary standpoint have metabolic and psychological outcomes that actually enhance treatment? That's another interesting, maybe provocative question, and one that we're interested in pursuing in the future. So with that, I will acknowledge all of the wonderful people and collaborators, but particularly the patients, families, and their loved ones that participated in the research that we do. Without this, it would kind of just be a theoretical thought experiment, and we had the pleasure of being able to do this in an applied way. So with that, I guess I will open for Q&A, and thank you ahead of time for your anticipation or for your attention. Okay, so it looks like I got a question from Allie. Why wouldn't you target fear instead of disgust in treatment for anorexia? It's a really good question. The answer is a little complicated, but follow me here. So traditional fear response, and much of what we know about fear has to do with sort of an acute increase in arousal, easily measured, say, in a cardiac increase in input. And that sort of sympathetic arousal is part of what you're targeting in the context of exposure. You're demonstrating that it's not dangerous and that it will, extinguish over time, that if you expose this individual, that sympathetic arousal will attenuate. Our patient population actually has a stronger kind of parasympathetic overarousal as a baseline system. That makes it really hard to sort of generate the exposure environment in which you would do exposure to fear. And I think it's sort of a missed component of the psychophysiology of the disorder. It actually makes disgust much more likely a physiological response. Disgust does have a parasympathetic component to it. That stomach dropping, kind of queasy, uncomfortable feeling is sort of parasympathetically mediated. And so I think if we're really thinking if disgust has a role in this, exposure kind of maps, disgust-based exposure maps the basic physiology in starvation. Okay, from Philip. Is it known why eating disorders are relatively more prevalent in adolescent and in girls, and does age or gender impact treatment? Well, the first part of that question is no, we do not know why. We have some guesses, but we don't know why. And there's been actually just a really strikingly problematic absence of research on the sex differences in this disorder. And so does age or gender impact treatment? Certainly age does. It does in the context of adulthood versus adolescence. We have a much better prognosis for adolescents than we do adults. I wish I could answer the gender question. In fact, I lost my fight in the trial that we did to include people of all genders. Instead, I was asked to keep it female, and we sort of caved in order to get the trial done. But hopefully in the future, we'll be able to have more data to answer that question. Okay, Annabelle, would this type of treatment work similarly in adults? I don't know. I would love to try to find out. I suspect, being more humble about our expectation, I would say cautiously optimistic. Treatment in adults, as the data I showed you before, pretty sobering. And so to think we could get the same effect in adults, it's worth testing, but I think I would be conservative. I would say it's probably not quite enough. We'll probably have to be even more creative. Sabrina, what are the implications for higher weight individuals? That's a good question. I think, food avoidance, and particularly food avoidance related to disgust, can occur completely independent of weight. And so I see no reason why this model could not have similar application in people of different weight status. I think if you are able to understand what type of fundamental disturbance in eating an individual suffers with, that should dictate the treatment, not necessarily their weight. Okay, from Janine. Why target reevaluation of disgust associated with food avoidance rather than disgust associated with fat avoidance? Well, I don't think they're mutually exclusive. I think we focus on food avoidance first, in part because we have the fundamental challenge of trying to get folks to gain weight. And some part of that is fat, but some part of it is food overall. And it's hard to separate one from the other specifically. I'm not sure necessarily that the fat avoidance that occurs is fully conscious. With that, I mean, trying to eat a restrictive diet will often cut out fat without necessarily it being the specific thing that you're avoiding. I think oftentimes we hear patients present with carbohydrate avoidance, or they have preferences for the safety in foods such as clean food or foods that are associated with diet that inherently have already done the work for them. It's cut out the fat. So I think that's why we don't make it specific, but it's not necessarily mutually exclusive. Okay, from Aaron. In phase 3, when weight has been restored, what kind of treatments help maintain health? Do insight-oriented psychological treatments that help address body image, self-esteem, etc. help? Well, I guess the short answer is I don't know. I would like to be optimistic that they do. I think if you look at the adult data, what do we see? We see that even psychodynamically oriented treatment seems to do comparable to some of the behavioral treatments or more symptom-focused treatments that were developed for the disorder. I imagine that that would extend down age-wise, but it's worth testing. I think it's one of those things where it could be helpful, but we don't know if it's enough. And that's a big question that we have to answer. From Anonymous, do you think there is value in refeeding or doing exposure with calorie-dense foods, since avoidance of these foods might be a predictor of relapse? I think absolutely. In fact, if you attended our program, this would be something that would be built in just based off of what we learned. We think that focusing on these foods and to some degree this nutrition is an advantage, and we hope that it helps people after they get done with treatment be more resilient to the environment around them and more adaptable. Another anonymous question. Do you think that disgust can be targeted in treatment in regards to body image? I think it's a great question. I think 100% it can. Whether it's done the same way, I'm not so sure. I think we can be creative about it. You know, we do an intervention called mirror exposure in the program here, where you're confronted sort of with the image of yourself. But we often, in order to sort of escalate the exposures, will ask individuals more or less to elicit those symptoms via either consumption of a meal ahead of the mirror exposure, wearing clothes that make them feel uncomfortable or tight in a certain kind of way. And so we're eliciting at least the visceral symptoms. Whether it's specific to disgust, I'm not sure, but I think that would be a really interesting study to do. And I think it's probably thinking in the right direction. Okay, Gabrielle, have you studied the disgust and food avoidance that arises in pregnancy and its relationship to or lack thereof with anorexia? Super good question. We have not studied it, but I think it's really, kind of an interesting question to ask, particularly in the context of shifting hormonal environment. We know that hormones are probably playing some role in this that I didn't get into in this talk, but that might be some of the risk difference that we see between sexes, and that could be also manifested in different ways in an adaptive way for women when they're pregnant. And I think that would be kind of an interesting parallel study to do. Other question from Anonymous. Did your studies include individuals with ANBP subtype as well as ANR? Given that ANBP has a strong aspect of both food approach and avoidance, I'm curious about potential similarities and differences in mechanistic interventions. So we did include both restrictive and binge purge subtype. We stratified based off of diagnosis, so there was no differences between groups. I think, to your point, I think both food avoidance and food approach problems are present in that population, I think they can be treated individually. So in our case, targeting disgust and targeting the food avoidance part doesn't preclude or doesn't, might have a dual effect. It might have an advantage to sort of normalizing some of the excess approach behavior as well. It's one of the empirical questions that I think we can answer and maybe look at in a subtype kind of way in our population. So I think I've run out of questions. Wait, just as I say that, one more. Anonymous, you mentioned that the cannabinoid system may be implicated in treatments and relapse, but THC had no effect in AN. Why do you believe other cannabinoid system targeting treatments such as dietary fat would be effective? Great question. THC, some of this is a little bit related to the pharmacology, and then secondary to when they've tried THC in what context. So the studies that have tried THC have been in the context of inpatient treatment or a heavy refeeding schedule, and the outcomes have been weight. So we know it's pretty hard to do more than 2 to 3 pounds of weight gain per week, regardless of what you're doing pharmacologically. You're eating 4,000 plus calories a day. So whether you have a drug that increases your appetite or not, if your outcome is weight, the likelihood that you're going to find a difference is pretty small unless you're having a metabolic as opposed to behavioral effect or FF. And that's why I think the THC studies are hard to make sense of. They weren't really tried at the right time. I would recommend trying THC as a relapse prevention intervention when weight isn't necessarily the outcome. But as we saw, as I demonstrated in a lot of the work done at Columbia, across the park and other places, that during this vulnerable time, folks with anorexia are still not eating enough. And so if the appetite and reduced anxiety effects of THC and potential learning effects, which is particularly what we're interested in the context of that vulnerable period, we're able to help increase eating, I think that would be a win. But I think that question hasn't been asked. Now, dietary fat, it's really kind of the same mechanism, but we're not trying to flood the cannabinoid system as you would with THC. We're trying to increase the sort of synthesis of cannabinoids from dietary fat. And so hopefully trying to affect tone maybe more than the absolute amount of cannabinoid in and of itself. And so I think that's why dietary fat might have some implications. In addition, it sort of has, where THC has no nutritional value, at least dietary fat has other advantages outside of just that system. Anonymous question, do you think that disgust model could be used transdiagnostically with other eating disorders? I would like to think so. I think we have even less of an understanding of the role of disgust across other eating and weight disorders. Certainly, we've studied disgust in the context of OCD or certain kinds of trauma. And I think that there's enough sort of synergy and now kind of enough work being done, particularly in humans on disgust, that can allow us to kind of bring this work together and think about it transdiagnostically. So I think my short answer would be yes, but I do think that we have to kind of have a way to unify it. Interoceptive exposure might be one aspect of what would be a broader kind of transdiagnostic target for disgust. Okay, I think we have 1 more minute. Well, with that 1 minute, what I would like to do is just, thank everyone again for giving me, time and attention to be able to share this info and data with you, share the work of our program and our patients. Also tolerating some of the technical issues I had in the beginning. So sorry about that. And otherwise, I appreciate everything. And hopefully, if you're interested, you can check us out online, or otherwise, have a good day. I appreciate it. Thanks, everyone.